Welcome to the Hospital Finance Podcast, your go-to source for information and insights that can help you stay ahead of the challenges impacting healthcare finance. And now, the host of the Hospital Finance Podcast, Michael Passanante.
Hi, this is Mike Passanante, and welcome back to the Hospital Finance Podcast. You know, these days it's important for hospitals to collect on every dollar that they've earned, and one way to do that is to strengthen the healthcare revenue cycle, and there are many ways to go about that. But what we're going to be bringing to you today is the actual experience, or a case study, if you will, from two of our team members who in a former life worked at a hospital together and worked on some pretty interesting initiatives around their revenue cycle and saw some pretty dramatic results. So today I'm joined by Olga Barone-Allan, who is a client relations manager here at BESLER, and Meliza Weiner, who is a manager and clinical review nurse. So welcome to the show, both of you.
Thank you for having us.
Thank you, Mike.
So, as I mentioned, you were both involved in a cross-functional team effort to improve revenue cycle operations at a hospital here in New Jersey. Tell me what motivated the team to put a working group like this together.
So, my role at the hospital was director of PFS. Meliza was the director of case management, and she'll probably speak a little bit more about that. But when we first met each other, we were asked by the CFO to initiate a collaborative meeting between the various departments involving the revenue cycle. Previously, these departments were working in silos, so there was really no communication, and the impact of some of the decisions or some of the actions that were taken in these departments would affect the reimbursement at the end of the cycle, which really geared the CFO to pull all these departments together in conjunction with the CIO, having the CIO's backing. So as part of the initiative, she had pulled together the registration department, case management, HIM, PFS, and the ancillary departments, but they were called into to the meetings, and they were weekly meetings, and we would all attend, and we would start creating tools, and we had KPI tools, key performance measures, and denial rates, unbilled charges, late charges. These were tools that we used to try and improve processes. One of the major things that Meliza and I, one of the top items that we had to focus on was the observations. Mm-hmm. And the problem that this provider was having at the time was that they were changing the patient status of these accounts from an observation to an inpatient to an ER patient. And this was happening within the mainframe system. What impact this was having was mischarges and incorrect reimbursement rates. So we collaboratively met each other and really believed in the initiative, and I'll let Meliza speak a little bit on, from her perspective, what this meant and how this enlightened her and her department in the initiative that we took.
I think to Olga's point, one of the issues that was also brought up, like she mentioned, one of the key performance indicators that we were having an issue with is denials, and also the switching back and forth between observation and inpatients. And what was happening because of that on her end, as far as the finance end, they were having problems with billing. Are we billing observation? Are we billing the days? Are we billing inpatient? And because of this, Ms. Stacy was creating sort of a chaotic scene on her end, not to mention also in the inpatient scene, because of switching back and forth requires physician involvement as far as documentation, writing the orders. So there was a lot of, should we say, misunderstanding, and then it was impacting our denial rate, and at the end, it was impacting dollars that was bringing into the provider that we were working for at that time.
Well, that's one great example of how you can collaborate as a team to sort of address what's really a clinical and a financial issue, right? So I do want to unpack this a little bit more. So talk to me, you know, when you got together in this large group, how did you go about thinking about the goals that you wanted to achieve, deciding what they would be, and then prioritizing them?
So what we did, the first month that the meetings or this group started to get together, we started to pull together denial rate, unbilled charges, our DNFB, any billing edit, scrubber edits, and what we did was we sorted it high to low by number of accounts and total dollars, obviously. And what the common theme that we saw on all these reports were the observation. Correct. So we dug down to see what was the core issue, what was creating our observation claims from not being billed out because they were being prevented from the billing. And then when the few that were going through the process, why were they being denied? So what we did was we took the regulations for Medicare. We analyzed that, and it was also an educational process for everybody, because what we learned during this process was how to really identify carving out hours from transporting a patient from one area to another. And that is always it's not always on the forefront of everybody's agenda. So it was very manual. And that's where we needed the buy-in from the CIO and the CFO, because it was a very manual process. And as you know, rounding up, rounding down hours for transport, it's a very tedious job in keeping track of that. So with the collaboration and support of the CFO and CIO, we were able, within the mainframe system and with case management and HIM and the ER department registration, to be able to identify these claims and make sure that from day one they were going to the various departments that needed to actually code it correctly, make sure the patient status was the correct patient status from day one, and then calculate the hours, carving out the transfer hours out before the bill. So the DNFB for those claims, we had reduced it down to maybe 4 or 5 days, which was tremendous, because we had claims that were out there for 3 to 4 months sitting there, which impacts, obviously, reimbursement.
Right.
And, what we did was we took that education, and Meliza can, speak to the education part. She was bringing this back to the nurses. And
correct. So to add to what Olga is saying, we also identified that the education piece, and I understand clinicians went to school to be clinicians, and we wanted to keep it that way, but we want to make sure that the process is in place, started at the beginning, and identify them early on. And if we are moving them from one department to another department, we have to streamline that. So we also involved other departments like the radiology departments, the lab department, the emergency room department, so that when we are working with these patients, we know how to work on this claim. Is this an observation from the beginning? And if it's an observation, then we already know how we're going to bill them, what we are looking for as far as hours. If they were considered inpatient, then we already know how we're working with that. So getting the right status at the beginning, so at the end we're not switching back and forth between observation and then changing them to inpatient and then switching them back to observation, because that alone is just tedious, trying to keep track of what the charges are going to be.
Right, and like Meliza said, the issue we were finding was not only were we missing charges because of the patient status changing, but we were also missing specific codes that need to get on the bill. Right. And I think that one of the things that once everybody in the room, the various department heads, the ancillary departments, ER, case management, HIM, we realized, the motto became, hey, we want to get paid on everything we did. And that was our goal. That was our mission. That was our, what drove us. Because we realized, they realized more than we did, because we knew we weren't getting paid properly. But they realized, oh, wow, we did all this work and we're not getting paid.
Right.
Like, they were amazed.
It was like an aha moment.
Yeah, it was an aha moment. And then they were really motivated and passionate about, the service, that procedure.
Mm-hmm.
I want to drill in on something you said a few minutes ago around working with the CIO, because anyone that's involved in health IT, as we are these days, knows that the CIO is I don't say overwhelmed. Maybe many of them would say that they are. There's so many different aspects that they're responsible for, not only from just running the technology at the hospital, making sure all that goes smoothly, but cybersecurity and lots of other things that fall under their aegis. And so, how do you get that CIO engaged? If you're coming in from sort of a mid-level or hopefully from a CFO perspective, is dealing with their peer, but how do you get them to understand that this is an issue?
I think at the beginning is to bring them at the beginning when you're in the planning phase and what the goal is, and to get them to understand how their department plays a key role in the initiative. And I think the other thing with our CIO at the time is also being backed up by the CFO, because that's another tie in there, is having the CFO backing it up and knowing that the initiative, it was a collaborative initiative, that it was all our goal to get where we want, and it involves everybody. Having the CIO at the beginning and understanding how much of an impact and how much revenue we're going to lose if we don't put this in place, and putting that, quantifying it for them as far as their impact, I think is one of the key aspects of getting the CIO involved.
Yeah, and the other thing was when we sat down and initially showed the trend between the various reports and the highest impacted opportunity that we had, and when we explained to the CIO and the CFO the manual process that was involved in getting this achieved, they were like, why are we doing this? You need 5 people to handle this, one from each department. Why can't we do this systematically? And we that's why we need you. So we were able, and then the savings, or what we were able to achieve by this was that by improving this process, they realized that how much more money they would be able to obtain for an organization, and it makes them look good if they're able to report at senior leadership meetings that they've improved their cash collection by this much because an improvement, that departments that were not talking previously are collaborating and improving. It makes them really look good. So they were really engaged. And, don't get me wrong, they didn't attend every single meeting. They attended the first couple of meetings, and then they handed it off to, me. And then, Meliza was the representative from case management. And then, so we would report back on a regular basis to them, and then we would show numbers. So we were constantly showing the improvements, and it showed in our clean claim rate, in our DNFB. We were able to bring that down and turn that around. So the numbers don't lie. So when we were showing them that feedback, they were so engaged. And with the CIO's involvement and his support, their support, we were able to load a slew of like 23 work queues within the mainframe, which is really even before it gets to the billing scrubber. And so that was a major accomplishment.
So we talked about ways to get people on board and the satisfaction of how that looks when it works. Who wasn't on board?
I would say initially the ancillary departments were not on board. They just did not understand. They were convinced that every charge that they provided was making it to the bills. And when we proved to them that the bills were not representative of everything, and they had a budget to adhere to within their own department, and they realized that they tied the loss of revenue was tying into their budget, then it clicked. Initially, contract management was not involved, and that was tough because, when you adjust a claim or change a claim in a mainframe, you have to reprorate a claim so that it's, calculating to the net, so it's not sitting on your receivables at gross. We were a bit behind on that as an organization. The other thing was we didn't have a charge master department. So that was very key. Our charges needed to be updated, needed to need to be created. There were certain services we didn't even have charges for because there wasn't a designated department. So we were able to convince the CFO to get a vendor to come in and help us bring us up to speed. So all those things, really, it was a whirlwind of different actions going on. But it ultimately, everybody within that team, still to this day, remembers it. In the beginning it was rough, but at the end they really realized the major impact, and a lot of it was copied over to corporate. So everything we did was cookie cut. It was like copied and brought over to corporate. So it was a great initiative.
What advice would you give a hospital that's considering putting together a cross-functional initiative of any kind to improve revenue cycle?
I think one of the things that needs to be addressed at the beginning is you have to make sure that you have a buy-in of every department that's going to be impacted by this collaborative initiative. You can't work on a collaborative and not involve certain departments. So one of the things that we did is we involved everybody at the beginning and saying at the beginning, look, we're starting this, and if for some reason it was determined that we don't need you to come on a weekly basis, we're going to invite you on a monthly basis if it affects your processes. And I think just starting that at the beginning and starting proactively would work. The other thing also is to see the knowledge and do an assessment of the knowledge of the teams that you're going to get involved. How much do they really know on what this initiative is going to be? Because the first thing, and I'll tell you this from experience, the first thing when they say, okay, we're doing this collaborative project, the first thing, another thing on my plate, another thing for me to do, I have all of this going on in operations. I think is to educate them first at the beginning. This is what we're going to be doing, and this is the reasons why. What is your understanding of it? If they don't understand, educate first before getting them to do some work, because they get defensive.
I would say definitely show them the numbers. Yeah. Showing them the numbers and the impact that it has to their department directly makes it just a light bulb goes up. They really don't know the impact. A department knows they perform a service and they record it. They don't know that it's not making it on a bill, or the way they're putting it on a bill is the incorrect way. So by showing them the loss of money or the denial rate or the mischarge, it has a tremendous impact on them.
And then you have to celebrate the success.
Yes.
Even if it's so small or so tiny, you have to celebrate the success. Because I remember would go back to what we have at the time, the Medical Quality Council, where the physician heads sit on it. And I would bring in the report from our team, and I said, just this small initiative of what we did when we implemented case management in the emergency room. Our denials went down. We were able to bill more when it comes to observation charges. They were happy. They were ecstatic because just this little effort made a great impact. And so they keep wanting to do more. Yep.
Olga and Meliza, thanks for coming by and sharing that very rich experience with us. We certainly appreciate it, and I'm sure our audience does as well.
Thank you for inviting us.
Thank you.
If you enjoy the Hospital Finance Podcast, please head up to iTunes to subscribe and leave us a positive review.
This concludes today's episode of the Hospital Finance Podcast. For show notes and additional resources to help you protect and enhance revenue at your hospital, visit BESLER.com/podcasts. The Hospital Finance Podcast is a production of BESLER. Smart about revenue, tenacious about results.